Awesome. Cool. All right, so I'll go ahead and get started. This is not so much relevant to care done at Violent, but very relevant to when you guys are at the any CB ICU. It's your guys' responsibility to care for these patients post TAVR. And so really what I've put together is a small little playbook of things you guys should expect, things you guys should know, something you guys really should take seriously because, obviously through our fellowship, everyone should be prepared at the end of graduation to be able to get a job in a CVICU. And one of the, obviously most common procedures done is a TAVR. So why is it important? Well, the prevalence of moderate to severe AS is insanely high, especially in older people, and more as we get more good data, which I'll briefly go over on the outcomes of TAVR. This procedure is, being done very, very commonly. Prior to maybe 10, 12 years ago, surgical aortic valve replacements was the most common procedure done. I mean, this was like the standard of care for valve replacements. And then obviously through a series of trials known as the partner trials, and there's really 4 big ones and another one coming out soon. We've really moved from going from surgical aortic valve replacements to the TAVR, which is through the aorta. And kind of as a brief overview of what these trials showed. So the initial trial in 2010 came out called a partner trial, and it really introduced the TAVR as like an alternative to SAVR for really high risk patients. And when you kind of looked at the two, it showed similar efficacy between the TAVR and SAVR, but with really different like adverse event profiles. And really what they were looking at was like the difference in stroke rates, a very common problem with these procedures. And then right after that came out the Partner A trial, and that really demonstrated that the TAVR had a lower risk for all-cause mortality or stroke within 2 years compared to SAVR, but sorry, a much higher risk, and that kind of like made people kind of concerned about it. There are obviously qualms about that trial, but the long-term follow-up really didn't show any significant difference. Fast forward 2016, the Partner 2 trial expanded the use of TAVR to intermediate risk patients, and it also showed that TAVR had a similar efficacy as SAVR, but with different adverse event profiles. You can kind of see like all-cause mortality. The one thing that was really concerning was a significantly higher risk of moderate to severe aortic regurgitation from the SAVR compared to from the TAVR compared to a SAVR. And then Partner 3 came out in 2019, and that showed TAVR to be superior to SAVR for the majority of outcomes in low-risk patients, and really supported the FDA's approval for TAVR for low-risk patients, even though some still kind of argue that the evidence is not good enough. And so when you talk about what kind of patient is going to be getting a TAVR, we're really looking at patients with severe AS. Not a full overview of the echocardiographic findings, but really the way I remember, at bedside, if you're thinking that someone has severe AS, then you should refer one of these patients in discussion with your cardiologist to someone that should get this done, say from our ICU. You're looking at like that 44-1 rule. So, when you guys put the probe on, you want your mean gradient greater than 40 millimeters of mercury, that peak velocity greater than 4. If you guys ever want to see how to calculate this, just, grab me, grab anyone else. We'll show you how to do it. It's very similar to like basically getting your LVOT VTI, then getting that aortic valve area, and that's less than 1. The dimensional index I really like because I don't know if anyone's familiar with it, but it really uses that continuity equation. And so the idea is that like you don't have to rely on your LVOT cross-sectional area, which is usually a very common cause of errors in assessment in these values. And so what you're really saying is that if you have flow going to the LVOT, that same amount of volume should really go through the aorta, right? So if you take your area times your velocity, or your stroke volume, and then you take your area times your velocity, it should really be equal the same. So the dimensionless index is really the ratio of the LVOT VTI to that of the aortic valve VTI, the jet that you're getting at that aortic valve. And as you can see, like your VT, if you have really severe AS, the smaller that ratio is, the worse that aortic stenosis is, that smaller that ratio is going to be. Your LVOT VTI is going to be much smaller than your aorta VTI. And so obviously keeping in mind, there's a lot of caution of AS diagnosis in patients with heart failure. This is kind of where you get to the really nitty-gritty stuff. These patients should be followed routinely with cardiologists outpatient to decide if they're a good candidate, because it can make the diagnosis very challenging, right? So, I mean, we won't get into it now, but in patients with like heart failure with reduced ejection fraction, they may not meet that classic criteria because you have like errors in like your measurement of aortic valve area. They may have like pseudo-severe AS. They have reduced ejection fraction, so their contractile reserve is very low, Or what they'll have is that like that you guys will see on the echo boards, but low flow, low gradient AS. And then you'll also see similar issues in patients with heart failure because like you have like disproportionately low flow or gradient compared to which will likely happen like due to your aortic valve area. And then the common term that you'll see is like paradoxical low flow, low gradient. Some of the more advanced stuff, but really relying on your cardiologist here to decide if they're going to be a candidate or not. So you've made that diagnosis of severe AS. That's still not enough of an indication to get this procedure done, right? So there's a few more things that we're looking at. You're seeing, are they symptomatic, right? Are they going to be a high surgical risk? And you're really getting your other providers involved, right? Like your cardiac clearance, your primary care doc, your pulmonologist if they have other issues, because these patients with severe AS usually have other complications or other comorbidities, and you want to make sure that they're optimized as possible. And so now you as the intensivist who's going to be helping to manage these patients who the cardiologists, the cardiac surgeons are relying on you to properly take care of these patients are going to expect for you to have a good procedural understanding of a TAVR and how it's done. So when you guys are looking at it, there's various access sites that can be done. Really, you break it down into like anterograde versus retrograde. And the simple way to think about it is that it's going to be either done before the aortic valve or after the aortic valve. So are you going to go in from into the aorta and then go backwards and implant the valve? Or can you do it, like for example, transapical, they'll create a hole at the apex of the heart and then enter the valve that way. So it's really important to kind of understand the different ways to do it. Those are kind of the more common ones. What you'll see most commonly is like a subclavian approach or a femoral approach. Now, let me see if this video works. Hope you guys can see the video okay. So we'll kind of keep it quick. So the patient's already been brought, they've had a bunch of tests done, EKG, CAT scans, the works. They roll into the OR, sometimes like the cath lab or a combo room, all prepped and ready. The access point for the new valve, like we talked about, can vary. It really depends on like the type of scans that the patient's had and like the patient's arteries and things like that. Anesthesia is given. They get a whole bunch of lines and tubes, A-lines, pacemaker, sometimes even a Foley. Sometimes they'll do the balloon valvuloplasty first to make room for the new valve. And then here's the cool part. So the valve is delivered and expanded, usually while the heart's pacing is jacked up to keep things still. So this can be done either via the right ventricle or in newer technologies allow you to do the left ventricle. And then then you kind of use real-time TE throughout this entire procedure to make sure that everything's appropriately in place, that you're at the appropriate area. And then finally, you'll see that like now they're really taking that valve, taking it into where the aortic valve area is. And then once again, what they'll see is they'll jack up the heart rate called rapid ventricular pacing so that the valve stays still, and then they'll expand the valve and then kind of take it over from there. That's really the entirety of the TAVR procedure. Significantly shorter than and less complicated than a surgical aortic valve replacement. And obviously, as technologies advance, there's all these cool new nuances that you can kind of see, additional devices like for stroke prevention and all that. But that's really the basic overview of the procedure. So now here's the fun part, right? The patient is now coming to the ICU after they've gotten this TAVR done for post-op monitoring. So they just roll out of the OR. The first thing you got to do is you got to talk to the OR team, get like the lowdown on how things went. Use a checklist if you have to, have an internal one, because really you're like the quarterback in the ICU. Your job is like to steer the patient away from like a minefield of complications, and really you're aiming for quick wins, right? Like pulling the tube within 24 hours, getting up, standing, and walking by day 2, aiming for discharge by end of day 2 or day 3, and then throughout that entire time, really keeping your eyes peeled for any hiccups and dealing with them ASAP. So like post-op handoff can really include like understanding what pre-procedural comorbidities they have, any peri-procedural events that happen, especially around the valve or the balloon placement, all the entry sites that happen during the procedure, anywhere where they cannulated, you have to know about it. What were the outcomes of the valve? Like, were there any issues? Was there any regurg? Like, what did the anesthesiologist see when they were doing the TE? What were the aortogram findings? How did the patient tolerate overdrive pacing, right? Because there's good data to show that like when overdrive pacing is done, and sometimes now even with newer technologies, you can avoid it altogether. But did the patient tolerate it well? Because it can lead to, risk of persistent or recurrent arrhythmias, AKIs, and things like that. And then obviously like the usual stuff, right? That we ask for our post-op patients, like what was the analgesia sedation given? Were there any pressor requirements, complications, blood loss, etc. I really like this diagram. So like, when we talk about it, of all the things that you kind of want to watch for in the first 2 days, first up is like the vent, right? We're all big fans of getting that tube out as soon as possible. And the thing to know about TAVR patients is like these patients have been sick beforehand, right? And studies on heart surgery patients show that early extubation doesn't, jack up the risk, but does show that folks get out of the ICU faster. So it's obviously like just more comfortable for the patient. And then, when you talk about like costs and things like that, obviously getting them extubated is faster. But TAVR patients are like a different breed, right? They're high risk. They often come with those other issues like I talked about, like lung disease, heart problems. So if you take that tube out too soon, it could actually make things worse for them. And the way I would think about it is like bad stuff that can happen when you pull the ventilator will just affect these patients a lot harder. So you have to like play it by ear, use your usual vent parameters, seeing are they really dependent on that afterload, and then obviously continuing those early extubation protocols that we talk about. And then trying to get the Foley out within the first day, especially if they don't need it, keeping a close eye on the urine output. Same thing, like at a lot of hospitals, almost everyone gets a Swan Gans catheter, getting it out after the first day if you don't need it, maybe potentially by day 2. That first day, bed rest. And then, getting that echo done. Obviously, sometimes, surgical patients can be higher, a lot of like, it's really hard to get good views, but you shouldn't have that issue with TAVRs. You know, very, very close eye, especially after you wean off the sedation on your neuro exam, because stroke is one of the most common complications that you can see in these patients. And it's very important to get a good neuro exam. Rely on your nurses as well, make sure there's no discrepancies. The last thing that your cardiologist or surgeon want to hear is that they're surprised by your neuro exam and, we didn't catch it early. By day 2, like after that first day, you can start advancing the diet after you have them extubated. Nutrition here is extremely important. It's a big deal in these patients because, patients with like low albumin levels, very small BMIs, it can be a lot of trouble for valve surgery. So as soon as that tube's out, get them eating. And really what you're aiming for is like, some recommendations are 120 to 130% of what they normally eat. It's a good starting point, especially for those with like heart failure. And so, to kind of sum it up, get the tube out when you can, get them out of bed, get them walking by day 2, and then aim for discharge by no later than day 3, provided there are no complications, no hiccup. And that's really a summary of like the best case scenario, right? But why we have to be there, why we're the quarterback in the ICU is because of all these many complications that can happen, and we have to be aware of them. They're different than our routine patients. Now, what they joked around about was they called it like the big 5 of complications. And the reason there was like, I tried to find where this name, the big 5, came from. They joked around about it's like, in South Africa, when you're like just going out and about, there's like these 5 animals that you could just come across, and like these are the patients that you just get extremely scared about. And these are the ones that you just absolutely have to watch out for. Same analogy in the ICU, these are the complications that you watch out for. And I think that's changed over the last 10 years as like our technology has changed and like overall ICU care has gotten better for these patients, especially considering how often they are. But like the one that we get really concerned about a lot is stroke, very high incidence, right? And most of these happen during the procedure itself. Why? Because like, think about it, you're going in and a lot of debris can get loose from the aorta and valve, right? These patients usually have heart disease, they can have calcifications, they can have like plaque throughout. So you want to like, ideally minimize messing around with catheters and valves. There's a lot of research, and that could be a whole lecture on its own on like cerebral embolic protection devices. There's just so much data on there, like a lot of discussion, like whether it's cost effective or not, and like, do you anticoagulate? Do you put these patients on antiplatelet? But the thing for you guys to know is that symptoms can show up more than like 24 hours after the TAVR, right? So you have to look at other culprits too, like, could there have been like a delayed embolization? Did they have any AFib, something that can happen because of this procedure? New onset AFib can, happen in about like 20 to 32% of these cases. And then if you're not on anticoagulation because you just had this big procedure, your stroke risk is going to skyrocket. So, in terms of like a game plan, if there's no AFib, antiplatelet therapy, sometimes dual antiplatelet therapy. If you have AFib, then you're going to be on an anticoagulant. And obviously, you as the intensivist will be advocating for avoiding triple therapy because in a patient like this can be a mess. So really bottom line is like keep an eye out for stroke signs, especially this new AFib. And then really, I think next few years, we're really going to be hoping for some interesting data on the best like antithrombotic strategy, especially those like cerebral protection devices, which I think are pretty cool. Um, So the next one is like, bleeding, right? You have to keep an eye on their hemodynamics, on their, CBPs, their hemoglobins. Because if you've got a patient post TAVR and their blood levels are dropping, the first thing that you're thinking is like, this is bleeding until proven otherwise. And bleeding in these cases are no joke. Like when you have major bleeding, 14% of them become life-threatening bleeds. So you really have to pay attention to that. Step one, check your vascular access sites. See if there's a hematoma. If there is, measure it, mark it. If you can't stop the bleeding with just pressure, then obviously you need to like be in constant communication with your vascular surgeon. No hematoma, like look for hidden bleeders, right? So like abdomen, retroperitoneum, get a CT scan as long as they're stable. If it's a retroperitoneal bleed, you're gonna need a surgeon or like IR, like yesterday. Vascular complications can happen, much higher incidence in women and like, folks with like small arteries, which is obviously a high incidence in these patients. And sometimes the bleed isn't vascular, right? Like check the GI tract, very common medicine question, right? These patients are prone to GI bleeds, right? You guys remember that term Hyde syndrome? And then, patients with AS have a high incidence of bleeds, of GI bleeds. And then obviously, don't forget to look for other causes of anemia, like, issues with red cell blood production, destruction, all your usual culprits. Transfusion targets, data still up in the air. Some will say 7, some will say 8, especially given it's a cardiac surgery patient. But really, to sum it up, if they're anemic, assume they're bleeding, find it, fix it, and then keep an eye on those hemoglobin levels. Arrhythmias post TAVR, you've got a new valve in. Guess what? Like the valve's neighbor is the left bundle branch, right? So very high risk of life-threatening arrhythmias. High chance of left bundle branch block. Like I think the last stats I could find was like with the Medtronic 48% versus like 21% with the Edwards valve. And some patients will need a permanent pacemaker, like 18% with the Medtronic and 4% with the Edwards valve. And these conduction issues aren't going to show up right away. They'll like usually come in after the first day or two. So if you've got risk factors like maybe a Medtronic valve, then or a pre-existing right bundle branch block, then obviously telemonitoring, review the strips if there's any change, make sure there's no electrolyte issues. And sometimes they'll even consider keeping in a more longer pacemaker in before the TAVR. And if you've got like a new conduction defect after the TAVR, the jury's still out on how long to keep a temporary pacemaker in. It really varies, but you're discussing this thing very closely with your cardiologists and surgeons. Majority of the times, if they see these arrhythmias, they'll bounce back on their own. And, like I'll go into one of the common issues, but sometimes as they get the valve bigger and bigger to address like leaks, that can potentially lead to a higher risk of these arrhythmias that you'll see. And now this one's extremely important because kidneys can definitely take a hit after TAVR, and we're talking like 7 to 12% of patients getting AKIs. The more severe it is, the higher risk of comorbidities or complications, especially down the line. And all the same risk factors like transfusions, blood pressures, lung issues, already messed up kidneys. These are things that pretend poor prognosis for these patients. So if AKI shows up, it's pretty bad news, and our cardiologists and surgeons hate it. Can lead to like longer hospital stays, more costs, and like we talked about, higher chance of morbidity. So you do your usual workup, right? Like low blood flow to the kidneys, tiny clots, contrast, allergies. Our goal is really to try and stop it before it gets worse. Keep them hydrated, go using the contrast if the kidneys are already kind of shaky. Utilize your ultrasound and if your intervention, see if your parameters improve for those of you guys that are savvy with it. Very close eye on the urine output and daily blood tests. And then if things go south, act fast. Check for blockages, look at the quality of the urine, and then fix anything that could be choking off blood flow to the kidneys. Diuresis if they're congested, things like that. And then obviously the usual stuff, keeping an eye on the meds that could be nephrotoxic. And then, if things are getting worse, right? Like life-threatening levels of acidemia or hyperkalemia, be ready to dialyze. It's a really, really big deal. Watch for it, fight it, and then keep those kidneys working. Now, the next one, paravalvular leaks. This used to be like considered like the Achilles heel of the procedure, but with newer gen devices, we don't really see it as much because devices are obviously better. These days, we see a very low rate of these leaks compared to like some of the older technologies, the older valves. But you can still see complications in patients with like, such like bicuspid aortic valve, something you still have to be aware of. And then this one, you kind of just, discussing with your cardiologist, relying on your imaging. So that kind of sums up some of the big stuff. What I'll do is, we'll walk through a case. If you guys, have thoughts on this, like, let me know what you think. This isn't a case that I saw, but a case that I found a paper on. But really the idea is like have a systematic approach. And then, if you're in the CVICU, like what's your approach going to really be? And then if you haven't listened to Cardio Nerds, amazing podcast. They have a couple cool cases on problems with TAVR that they manage in the ICU afterwards. So your patient just came out of the OR, right? And we talked about like the first thing that you're going to do is you're going to talk to your OR team, right? The anesthesiologist, the surgeon, the cardiologist. Here's a 70-year-old female. She's got a history of CAD. She had PCI done. She had 2 stents placed about 6 months ago, known AFib on anticoagulation, history of TIA, diabetes, hypertension. It's her first valve replacement. So she initially presents to the OR for elective TAVR, right? Per the report, they had successful implantation of like a 29 millimeter Medtronic valve. They had to keep the TVP, they used a right ventricular TVP and they kept that in. Via the FEM, and then she also has a Swan-Ganz catheter in place. Now, during the procedure, they were concerned that she started to become very shocky. They were concerned that, because they had to reverse the heparin with protamine, that this was a protamine reaction and an anaphylactic reaction. She became extremely hypotensive. They started giving her epi and things like that. But she became persistently hypotensive in a profound shock state and goes into a PEA arrest. So she gets CPR, right? They get her back up to 4 minutes. They bring her to the ICU after the TAVR. They're obviously concerned. They're discussing the case in detail with you. You know that everyone's relying on, everyone's got their eyes on you. We're all going to be doing like this multidisciplinary approach to figure out what's the best way to care for this patient. So just off the bat, how do you guys want to approach this patient? This patient's like in persistent shock. Their MAPs are in the 50s. They're on norepi, epi, and vaso. Anyone have any thoughts? It's a tough case, right?
Are we concerned about blood loss?
So I guess speak up a little bit.
I said one of the things I'd be concerned about is blood loss.
Yeah, absolutely, right? And so, if you're concerned about shock and there's like any, you're looking at your perfusion exam, so how are you going to assess for blood loss?
You can check the site and then do ultrasound, like a ultrasound to see if, like the retroperitoneal area that he bleeds, and then if the patient's stable enough, send for scans. Otherwise, just do bedside ultrasound to see, and then your physical exam.
Yeah, absolutely, right? You really want to keep a close eye. All your usual stuff, like perfusion exam. Remember, this patient has a Swan-Ganz catheter. If you're expecting blood loss, what do you expect to see? Like, what would be your CVP, high or low?
Low.
Right? And so you're same with your wedge, right? You expect to be low, right? Because the concern here might be hypovolemia, right? You'll see cool extremities, poor capillary refill. So you consider giving them blood, right? Any other differentials?
She could have thrown a stroke, like a clot. Yeah, she could have stroked out.
Sorry?
She could have stroked out.
Yeah, I guess like why would her stroke would have caused her to have a PA arrest? Right, and this is like kind of also critical care thinking. Are you going to, in this really unstable patient, are you going to risk her becoming more unstable by taking off the pressors and finding out whether or not she had a stroke? And then on top of that, like, are you comfortable keeping her on the sedation because that may also be contributing to the hypotension, right?
Yeah.
Anaphylactic reactions to protamine is no joke. Like, risk factors like patients that have potentially been on NPH, because that has protamine in it. They could have been exposed to it and then sensitized to it. So definitely want to be aware of that. But would you keep this patient on epinephrine if you're concerned about anaphylaxis?
Yeah.
Yeah, absolutely, right? So, and so this was the EKG. Really nothing that stands out here. One of the things that you can be concerned about is an MI, right? So you can, if you guys look at where that valve is, right, you can obstruct your coronary flows and cause an MI. So you absolutely want to rule out, new onset cardiogenic shock, which you can also diagnose with your Swan-Ganz catheter. To make sure that you accidentally didn't occlude flow to your coronaries, right? Something definitely have to be concerned about. One of the things I didn't mention was like annular ruptures. Like that's a big complication, right? You're really relying on your imaging to rule that out. Patients with like lots of calcifications in their aorta, especially around that the valve area, high risk of annular rupture. Want to be something you want to keep in mind and discuss with your surgeons. Anything stand out on this chest X-ray? So kind of doing your usual stuff, right? Going down your algorithm, making sure like, is there a lot of, congestion? Could that be causing it? Any issues with my Swan-Ganz catheter, any pneumos, all the usual stuff, but then also paying attention to all these new lines that are in place. Right? Your like PA catheter looks appropriately in place. I'm comfortable with that. I don't see any other glaring issues on the X-ray. So once again, right, like just to review, right, there's patients in shock. You're trying to resuscitate them. Like I'm assuming a lot of them, based on what's been said so far, are considering giving blood products, are looking at your SWAN numbers. You're discussing all this with your team and making a multidisciplinary approach. Patient was overall pretty stable. Obviously, they've got some risk factors like CAD, AFib, prior TIA. They successfully placed that valve, but really post dilation is when they start to develop complications. And what is important to note, like this was not a VFib arrest, right? This patient's obviously like getting constant monitoring, and then they got him back pretty quickly, just doing CPR, right? So this is a pretty sick patient. You're pretty concerned. And the approach that I didn't have the SWAN numbers, but what I remember seeing it was like your wedge pressure is pretty high, your CVP is high, your RA pressures are high, and the patient's in like a persistent state of shock, right? So yes, you've got that usual circulatory shock approach, right? Like obstructive, distributive, hypovolemic, cardiogenic. And in these patients, like you really have to think and rule them all out because maybe it's not just one, right? So when you really think about it, it's like based on this, right? Low preload state, right? When you expect a lot of your pressures to be low, it could be hypovolemia, it could be bleeding. And so for that, you're going to transfuse, you're going to get source control, right? It could be a dynamic intracavitary gradient, right? And so like we'll kind of go into that a little more, but really you want to avoid your usual inotropes. It could be tamponade, right? So like depending on the way on the access site, right? If they went into the RV, they could cause like RV rupture, cause a tamponade. And for that, you'll have to do like an emergent pericardiocentesis. The patient, like we talked about, right, could be have a new MI, or they could just be in profound heart failure. Maybe they didn't tolerate that rapid ventricular pacing and now has like a really bad tachycardia-induced cardiomyopathy. And so now they're in obvious like, left-sided cardiogenic shock. Maybe through that vascular access, right? You're thinking like after the LV in the artery sites, they damage the aorta somewhere, and that could be the cause of the bleeding. And that's not going to be at your access site itself, or just because of like acidosis, sepsis, your usual distributive stuff. They have a significantly low SVR state. And then, so once again, you're really relying on these PA catheter numbers, your ultrasound, your physical exam, discussing it with your multidisciplinary team. The good thing is here is that you have a lot more data to utilize to help you make the diagnosis, right? So we talked about bleeding, right? So how are we going to rule out bleeding, right? So I think it's important in this case sometimes to, you may not look at this right away because you're obviously trying to resuscitate the patient, but you can rely on what your anesthesiologist, your cardiothoracic surgeon, your cardiologist see in the imaging. So this was like the pre-aortogram pictures done right before balloon insertion. No issues, good flow. And then this was like doing implantation of the valve. This is like, stuff that they'll probably be telling you. You can pull it up if you need to, but you can see like there's good flow in this from the valve to where it needs to be. And then this is where what it looks like post dilation, right? Once again, I'm not seeing any significant AR or aortic insufficiency. I'm not seeing any significant leak. And that to me is very reassuring, right? On top of that, the SWAN numbers don't really support a bleed. This was like images of the TE done. This is a short axis view. I don't know if anyone wants to interpret it, but you're basically seeing good flow out of the valve. This is the TEE mid-esophageal three-chamber view, and I'll get to that back in a second. But obviously, you're trying to resuscitate this patient. You're not going to know what's going on. They did have pictures of the aortogram done, which also, again, shows no obvious bleed, especially at the access sites, something that, a lot of times you won't have, but in this case is very helpful. Once again, this is that aortic root angiography, right? No AI, no leak. You're getting that full aorta view. No, trauma from that access that was done. And once again, I think that your SWAN numbers in this case, your exam is pretty supportive. That was, kind of not really supporting the bleed route. So what else could it be? So you've got a lot of data. How are you going to utilize all this data that we have to kind of rule out some of these other causes, right? And you guys know me, I'm extremely biased. When you lose focus, use focus, or focus on focus, when you really can't make the diagnosis, right? So if you guys are thinking that you want to grab a 2D echo and get a better view, then that's exactly what you want to do. And this is your parasternal long view. Anyone want to interpret it?
It looks like you have LVH. I'm not able to see too much of the RVOT. I don't know if it's just the access or it's completely collapsed.
Sorry, can you speak up a little bit?
Yeah, so I see LVH.
Yeah.
I'm not able to see too much of the RVOT. I don't know if it's just the access of it or if it's collapsed.
Yeah. Why do you think the patient has LVH?
I mean, probably the aortic stenosis.
Yeah, they've probably been dealing with aortic stenosis for a while, right? So they've developed LVH, right? Now, could this be contributing to shock?
Yeah, I mean, maybe.
How so?
Yeah.
I don't know, preload.
So pretend you give them volume. Do you expect them to improve? So this is really a no misdiagnosis, right? You're concerned that, sorry, go ahead.
No, you're asking if we give them volume, if they'll improve, and I said probably not.
Potentially, right? So if you're concerned that this is severe LVH, right, then what you're concerned about is that they're not getting enough flow through this, that their chamber is very, very small, right? Look at that gradient. How much volume do you think is actually in there, right? It looks like the LVH is so bad that intracavity gradient is almost like completely collapsed. It's completely obliterated. There's no space in the LV. So like, how much do you think the preload actually is in this patient, right? It's probably close to nothing, right? And on top of that, look at that LVH. You guys know what SAM is? You guys know what LVOTO obstruction is, like left ventricular outflow tract obstruction? Are you guys familiar with that? Right? It's like a no misdiagnosis because everything that you would routinely do for this patient in shock, right? Like right now we're on 30 of norepi, 5 of epi, and on days when this patient is sick, right? And like they came out of the ICU and their maps are still in the 50s, their perfusion is extremely poor. they're not getting much flow out of this valve. Now, what is norepinephrine and what is epinephrine? It's an inotrope, right? And so you are worsening that gradient. You are worsening that outflow tract obstruction by keeping them on this medication. You're obliterating that cavity even more. And so this diagnosis, the diagnosis here was called suicide LV, or a suicide left ventricle. It's, really similar to the overall physiology of a left ventricular outflow tract obstruction, right? So like think about hemodynamics post TAVR. You slap in a new valve, and what happened? The heart just got easier time pumping, right? There's less pressure to fight against, right? Initially, this valve has become extremely, extremely muscular, trying to push against this very small space because of severe AS. So all of a sudden, you replace this valve, and now the heart can pump a lot easier, right? And now, like, that's really great for the heart. You get less stress, more blood flow, but it's not all like, sunshine and rainbows, because now things get dicey, right? This heart is so used to working so hard that all of a sudden this pressure is gone. This big gigantic rock is just a small little rock, and now it doesn't even realize that with all this strength, it's just going to overdo it and fall off that cliff, right? And it's as bad as it sounds, because these hearts will suddenly tank. It'll lead to profound hypotension and shock. And really, you want to think about the patients that are at risk for this, right? Like patients with small hearts, high EFs. Like initially the EF was low or preserved, and now all of a sudden it goes up 60, 70%. And on top of that, if you're pumping them full of adrenaline, like we did with this patient, because we were concerned about anaphylaxis, this just made it worse. So I think in this case, this patient was dealing with a shock state. They thought it was an anaphylactic reaction, and then they just threw them overboard with the epinephrine. And so you're absolutely right. The fix here is volume. And then you don't want to do inotropes. You want to do just pure vasopressors. And that can really change your patient's recovery. So kind of in that simple approach, right? Suicide left ventricle, really similar to hypertrophic cardiomyopathy, treated just like left ventricular outflow tract obstruction. Initially, just like we talked about, they're dealing with all this afterload. They're compensating for it, have this chronic pressure overload. The moment you get rid of that, the moment that gigantic rock becomes a small one, and then, if you're even worse, if you're on inotropes, you'll just completely obliterate that cavity and impair any outflow. So treat it like LVOTO, give them a lot of preload, open up that LV, avoid excessive vasodilation. Use phenylephrine. That's your best friend here. You're saying it's cardiogenic shock. Why are you giving a pure vasopressor? Well, just like we talked about in dynamic LVOTO, it'll increase the afterload, and then it'll decrease that intracavitary gradient. And then through the nerve, it'll also kind of slow your heart rate down, which this patient is going to love and hate. It's going to love a slow heart rate, hate an extremely fast heart rate. So continue your beta blockers if you can to decrease that inotropy, and then that'll also increase your inotropic filling time. So overall, in review, keys to success, aim for those targets that we talked about in patients post TAVR, aim for that 48 to 72 hour discharge. Really, really, the moment you see any hint of a complication, call your cardiologist, call your cardiothoracic surgeons, keep that open loop of communication, and then have a systematic approach to complications. You guys are those inspiring intensivists. Be organized, have an approach, that way you guys don't miss anything. That's all I have. Obviously not that much management or experience myself, but Mike or Lindsay, you guys have a lot more experience than all of us. I don't know if you guys have any pearls to share.
That was awesome. I think it's an excellent but a kind of rare case example of some complications you can encounter. But it's an important thing to consider. This patient's physiology can really change after valve deployment. So definitely important to consider these features, and also all of the physical sort of structural challenges that happen when you have this valve deployment, not only from an MI perspective with the right coronary artery being most likely involved, and rhythm disturbances, and obviously you presented an excellent case regarding a less commonly encountered suicide LV dynamic, but all really important to consider these complications, all more so because most of these patients go down that kind of rapid TAVR pathway that all hospitals have. And so I find that when these patients come to us, it's so easy to just kind of forget and kind of just not really think of all the issues that can arise. Just because so commonly we don't have to deal with these patients because they actually are going, straight to, step down units and through kind of a rapid pathway. So when they come to us, they can be really sick. So it was an excellent discussion, excellent case presentation. Thank you.
Thanks.
Thanks, Uday.
Awesome. Do you have any questions? Cool. We'll take a few minute break and then Joanna will head up next. Maybe we can start around. Joanna, maybe you want to go like 4:17, 4:18?
You really kill me without being on like, the 4:20 or the 4:30.
4:20, go
Those
for it. I don't know how long
numbers.
you
5 minutes is fine. We'll try at
4:20.
4:19.
All right, 4:19 and 30 seconds.
It's like when we put the respiratory rate on the ventilator to 15.
don't you dare do that.